Introduction to the drugs used in ischemic heart disease. This will be done by Dr. Zagadin Jamaldeen, who is a consultant cardiologist attached to General Hospital Ratnapura. He's a well-known speaker, especially in this forum. Welcome, Dr. Jamaldeen. Floor is yours.
Good morning. Thank you for the kind introduction, Dr. Sandavali and Dr. Disna, for the panelist. So this is a very broad topic which I was given as a challenge because it's difficult to dealt with within 30 minutes. So I had to classify this is to summarize into 30 minutes. So what I mainly focus is drugs usually mainly in chronic stable angina rather than acute coronary syndrome, because I think in the morning first session the acute coronary syndrome has been discussed by Dr. Dhananjani Seneviratne. So just to recap, those who are not in the morning, just these are the coronary arteries which supplies blood to the heart, and this is very important because it provides the blood, the hemoglobin and the oxygen which nourishes the heart muscle and keep you alive since from your birth to death. So that means your heart has no rest and it has to function continuously. You can't take rest compared to other organs. So this picture shows how the ischemia occurs, what happens if the blood supply cut off, the affected, if comparing, this area, if it is blocked, it is zoomed here, so the supplying part will be affected because no blood, and that muscle is under vulnerable for ischemia, and if it is not intervened, the heart myocardium can die. But chronic stable angina is a different thing. You have some blood supply, and like in this picture, there is no complete block. There is some blood supply there, but it is inadequate it is enough for your routines day to day, but it may not enough when you exert yourself. So in that case, what should we do? So before we talk about medication, it is important that the mainstay of cardiac management, there are other things like lifestyle changes. Universally, everybody has to be practiced, and this regular exercise training, diet, the patient education, and treatment plus revascularization when it is indicated. So what are the aims of pharmacological management of a patient with ischemic heart disease? As I told you, now if you see this slide, it is all ischemic heart disease, but mainly I focus mainly the chronic stable angina. So to reduce angina is one of the main things from patient's point of view, because they worry their chest pain and also their chest pain while they were exercising. So that is very important from the patient's point of view, but from the doctor's point of view, it's also important to prevent future events like ischemic heart disease, acute coronary syndrome, MI, death, etc. So for the angina, if we go back this slide, angina now, as your allied health professionals, you think that the drugs for angina are mainly ISMN. It's not that the case always. Those are second line anti-anginal drugs. So the beta blockers and the calcium channel blockers are the first line anti-anginal drugs. Though the beta blockers and calcium channel beta blockers used in morbidity mortality prevention, but for ischemic heart disease patient with angina, it's a first line anti-anginal, as well as calcium channel blockers, mainly non-dihydropyridine drugs, that means the heart rate controlling medications. And there are evidence these things can be combined judiciously. So now the drugs as anti-anginals are mainly ISMN, ISDN, then the GTN or nitroglycerin, and other newer drugs like and this nicorandil, not a new, and other drugs, ranolazine, trimetazidine, and ibradine. So I'm going to give a brief. I'm going to brief on these medications in next few slides. First of all, we'll come to beta blockers, very well-known drug, and the main aim is to control your sympathetic output in the heart and dilate the vessels. So we are reducing the heart rate, that way we are reducing the workload of the heart and myocardial oxygen consumption. That is the main thing to reduce the angina. So it reduces contractility, it reduces cardiac output, as well as it reduces the blood pressure. And when the blood pressure goes down, or that means normal, the heart, the work has to be done by the heart is very minimal or low. So heart can rest to some extent. So beta blockers are very useful anti-anginal. As a first line anti-anginal, we have to give in an ischemic heart disease patient. So if you think the cocktail of ischemic heart disease drugs, you know there will be aspirin and there will be atorvastatin or statins and ISMN. These are the three things you usually see. But before starting ISMN, if there is no contraindication, patient should be on beta blockers. And the target heart rate we are aiming to reach is about 50 to 60 beats per minute. And don't stop beta blockers if you see heart rate 55 to 60 or 50 to 60, because that is the target we want to achieve. And as I said earlier, in MI and heart failure patients, it has good effects for reduced morbidity and mortality. There are a few side effects which only we have to consider. There are side effects if it is troublesome to the patient, mainly fatigue, depression. Like some patients can get bradycardia because of the this sensitivity of this pacemaker, natural pacemakers in our body, and some people can get heart block even. And you know very well that these things may be contraindicated in conditions like asthma, cardiogenic shock, or patients having already low heart rate. And also decompensated heart failure, though it's given in heart failure, the decompensated heart failure and acute LVF, you should be very cautious of giving beta blockers. Sometimes it's contraindicated. So going to the next drug is calcium channel blockers. There are two types, as I said earlier, rate controlling calcium channel blockers and rate enhancing calcium channel blockers. So the non-dihydropyridines are rate lowering ones, whereas dihydropyridines not rate lowering. So usually we give kind drugs like verapamil, diltiazem, but these are selected if the patient is having intolerance or contraindication for beta blockers, though it can be combined. The drug verapamil and diltiazem also acts on SA node, and it, as the name implies, it's a calcium channel blocker. So calcium is very important in myocardial contractility and vasoconstriction. So what these things does is this inhibits myocardial contractility as well as heart rate, reduces heart rate. So by this also and the peripheral vasodilatation. So by that it reduces preload and the venous return as well as the afterload because of the reduction of peripheral resistance. So this reduces the work to be done by the heart in a exercise or in exertion. So which produces, those are the things which produces angina. So giving these drugs we can reduce even exercise induced angina or effort angina. So there are side effects for these drugs as implied to beta blockers. It causes bradycardia, heart conduction blocks, and these drugs usually not given in established heart failure because of, though beta blockers given, it has mortality benefit effects, but calcium channel blockers, especially diltiazem and verapamil, is not given in established heart failure. And these also should be avoided in conditions like low heart rate conditions, but can be safely given in asthma patients. Few words about dihydropyridine agents, which are not rate reducing calcium channel blockers. These are nifedipine, amlodipine. There are preparations of long-acting nifedipine. I am not talking about nifedipine which are giving 20 milligram twice a day. This is not. There are long-acting preparations can be combined. If the heart rate is not a big issue, can combine with beta blockers. And these things can be given once a day and also used in effort angina, but not these drugs, especially dihydropyridine, is not considered as first-line anti-angina. There are side effects and should be avoided in certain conditions. Especially the commonest side effect is edema, peripheral edema, but it's not producing by the heart, it is a local effect with the gravity. And it also can cause reflex tachycardia. In that case, we have to limit the usage of these medications. This cannot be used in conditions like severe aortic stenosis, obstructive cardiomyopathy, etc. So the other important drug you are daily used, you know these are the anti-anginals, the drugs you think these are the only anti-anginals, but these are not the only anti-anginals, but this is the famous or favorite anti-anginals are the nitrates. There are two types, the acute, which is used in acute stage, those are short-acting like glyceryl trinitrate or GTN or TNT, and the long-acting ones like ISDN, ISMN, etc. And these again reduces the afterload and preload and vasodilate, and it especially it acts on peripheral vessels, not only coronaries. This is a small diagram of cartoon of action. It shows this nitric oxide is a potent vasodilator in our system. This nitrate stimulates this nitric oxide and it promotes cyclic GMP production, which inhibits myocardial contraction and peripheral this muscular contraction, which brings about peripheral vasodilatation. This is the GTN. There are tablet forms as well as sublingual forms, and there are sprays. And it's very important when you use GTN. Now, I am not going to explain all the GTN things, how do you keep in the shelf for those things. I think you should know these things. But giving in a sitting position is very important, because if you given in a standing position, patient can have fainting episodes because of the pulling down, and if you're given in the lying position, there is a rapid venous return can occur, not venous return, venous pooling can occur. So should be the ideal position is sitting position, and the maximum 3 doses within 15 minutes. Failing that, patient should seek medical advice. The long-acting nitrates are there. Second-line anti-anginals, nitroglycerins, like there are brands, even nitrates, and ISDN that need hepatic conversion, which is not used nowadays, because we have ISMN mononitrate, which have 100% availability. So that we use and this mononitrate preparation mostly. And the important thing is patient may not. Initially patient respond and patient later will get again angina. That may be due to tolerance developing for nitrates, not due to patient's real ischemic heart disease is going up. So in that case, rather than increasing the drug from 30 to 60 or 60 to 120, you can give a drug-free interval, because these drugs have a habit of developing tolerance. So just a small 10 to 14 hour interval of stopping or cessation is enough to break this tolerance, and then we can restart. There are the commonest side effect is about most of the patients, not most, majority can refuse this because of headache, and they can get other things, flushing, hypotension. In that case, we have to try a different same class anti-angina. These should not be given in hypertrophic obstructive cardiomyopathy or severe aortic stenosis, and should not be combined with sildenafil kind of medication. And we should ask these patients, now let's say patients with pulmonary hypertension, angina both, you can't combine, or patients who are having ED, erectile dysfunction problems, you can't give sildenafil if they are already on ISMN, or vice versa. That means if the patient is on sildenafil, you can't give nitrates. The nicorandil, other famous drug in day-to-day practice in angina, is a second-line drug. This acts via stimulating again nitric oxide in the cell and promote vasodilatation via cyclic GMP, and also it stimulates potassium channels, and this causes a reduction of intracellular calcium. So these are similar to action of nitrates, and side effects also could be similar, and in addition they can have nausea, vomiting, etc., and intestinal mucosal ulcerations, which are not very common. Another drug is ranolazine. This is a different preparation we have in Sri Lanka. We have 500 milligram. In some countries it has 375 milligram, the active metabolite. This is a drug blocks in the cellular level. There is a thing called late inward sodium current. By blocking this, it can again reduces the calcium. What we are trying to reduce the calcium overload within the cell, and thereby reducing the contraction. So this is one of the very effective medication, but again remind you, these are second line anti-anginal. Though it says second line, it looks like third line. That means you have to use first beta blockers or calcium channel blockers, then you have to add like nitrates or nitrates especially. Then the third line is this nicorandil or ranolazine. So these things can combine if the patient's having angina, refractory angina, but this is only a bridging thing until you are going for a permanent revascularization procedure. Or if the patient is not willing for revascularization, or patient is having other problems, you can't go for revascularization. In that case, we are combining these anti-anginals, 2 or 3 anti-anginals. So there are a few side effects, and main thing is if you're having a prolonged QT interval in ECG, you should be very cautious using this, because it can cause QT prolongation and arrhythmias. The other drug we are using is ivabradine for anti-anginal medication. This is act on SA node in your heart, and in the SA node there is a thing called IF channel. This is F stands for funny current, that is a sodium potassium ATPase, and this reduces your pacemaker potential. Pacemaker potential, let's say now 70 beats per minute, it reduces to 60 like. So there are indications and contraindications to use ivabradine. Always this is not as a first line drug, and in acute MI conditions you should not give ivabradine because it is contraindicated in acute MI. So imagine now this patient cannot be given beta blockers due to some other reasons like asthma. Still you may not be allowed to use ivabradine in acute MI angina. This is for chronic angina. So this is the how it acts on these channels, and this produces this is the normal heart rate potential, and it prolongs the heart rate potential by this ivabradine. The most common cardiovascular adverse reaction is bradycardia, as for beta blockers or calcium channel blockers, and these are given when beta blockers are contraindicated, or if you cannot get the heart rate while using beta blockers, can combine, but you should avoid in acute MIs as well as atrial fibrillation, because it can increase atrial fibrillation. Another drug, this is an all drug, but now it has come to the guidelines, the trimetazidine. This acts via, usually in our cardiac muscle cell there is fatty acid metabolism, and this prevents glucose utilization by the heart. When it prevents glucose utilization, then patient get angina. So this is the mechanism rationale to use trimetazidine. This prevents the fatty acid oxidation, thereby giving the chance of myocardial glucose utilization in your myocardial cell, and this prevents angina. This is one word for allopurinol, which is used in gout and chronic kidney disease to prevent gout. There are some evidence which still studies are going on. Appeared in 2019 ESA guidelines, and to use they need more studies and evidence. So this chart just I highlighted to show how you use. If you take the first column, The first step is use either beta blockers or calcium channel blockers. Then you can add combine these two, especially dihydropyridine plus beta blockers, because non-dihydropyridine if you use, it also reduces heart rate. This can cause severe bradycardia. And the third step is at the second line drug like nicorandil, iobradine, those kind of ranolazine, kind of etc. But there are other compelling indications. If the heart rate is high, what should you do? If the heart rate is low, how do you tackle? If there's LV dysfunction, low blood pressure, there are different scenarios. In that case, you have to give the, you have to think about the side effects and contraindications, etc. For the event prevention, we are, in addition to this angina, we have to use aspirin, clopidogrel, statins, etc. I think this has been dealt by Dr. Dhananjani in the first lecture. Just to recap, this aspirin, what does is it reduces platelet activation, adhesion and aggregation. This platelet is important in clot formation inside the vessel if there is a plaque rupture. So if you can see, there are multiple receptors in a platelet. Now there are receptors for aspirin, there are receptors. Now here the aspirin, which inhibits cyclooxygenase pathway. These are what we call P2Y12 inhibitors, which inhibits by this clopidogrel kind of medication. So aspirin blocks this and it reduces platelet recruitment and activation. By that it reduces platelet aggregation. That is the thing to prevent these platelet clots. And this is, I mean, in ischemic heart disease patient, this is used indefinitely if there is no contraindications. And a few words about clopidogrel. Clopidogrel, it acts via the liver, through the liver with this enzyme. There is enzyme. In some people, this clopidogrel is not, there are resistance. So in that case, other drugs are useful, but it has its own indications and contraindications. Like certain drugs we can't use in chronic stable angina, only in after acute coronary syndrome, like this prasugrel and ticagrelor. And other common drug we have seen in patients with angina is proton pump inhibitors. This is to prevent reduced GI bleeding, but it should not always be should combine. It should be combined if there is necessity arises. You can get cramps like thing with hypomagnesemia, and long-term therapy therefore should be judiciously used. And especially with omeprazole and esomeprazole, the clopidogrel action can go down because of it both competes one enzyme. That enzyme is this one, CYP2C19. A few words about statins. Statins are another important medication because cholesterol plaque is the cause to reduce your coronary arteries. So the statin which inhibits this cholesterol metabolism, and so it reduces intracellular cholesterol level. Because of that, it increases the LDL receptors on your cell, and it engulf or intake the LDL particles inside the blood, which is the most vulnerable things for your cholesterol plaque formation. So this reduces LDL cholesterol, VLDL remnants, IDL, very atherogenic these things, and it increases LDL receptors. So again, statins, if there is no contraindication, we have to use indefinitely for these patients. And these are few examples of drugs. And I am not going to talk about these streptokinase, tenecteplase, tissue plasminogen activators, which are used as thrombolytics in STEMI, and other oral anticoagulants like or parenteral oral anticoagulant. VK is vitamin K antagonist, the warfarin, and there are new agents. These are novel agents of anticoagulants, rivaroxaban kind of medication, apixaban, and the other famous drugs, heparin. So these are the beyond of the scope. So the main aim of this session is to discuss these anti-anginals and other important drugs. Thank you very much.
Thank you very much, Damaldeen, for your excellent lecture. I would like to invite you to the panel, and Now the panel is open for the questions. Until we get the questions from our online audience, Jamal, I would like to ask, do you like to mention anything about nitrocontin? Because that is also a drug that they use when in ischemic heart disease.
This, I didn't use the term nitrocontin, but I mentioned about the nitrocontin because it's a brand. Nitrocontin is a nitroglycerin, which is a long-acting nitroglycerin. Usually we know the nitroglycerins are short-acting, which is used as a sublingual, but nitrocontin, one of the best drug available, which is a long-acting nitroglycerin, can be used as anti-angina.
Now, we have different kinds of beta blockers. Is there an advantage, now there are new ones, Nebula, that kind of beta blockers. Is there an advantage of giving Nebula over other beta blockers?
Yeah, there are, cardiac specific and other peripheral action beta blockers are there. Only thing is, when we use beta blockers, we have to think about the history of the patients, whether the patient is having angina, in addition to angina, whether they have peripheral vascular disease, intermittent claudication kind of thing. In that case, we have to be very cautious about using of these non-cardiac specific beta blockers. But nowadays, the trend is to use beta blockers like the drugs which are used for heart failure, the proven values like bisoprolol, carvedilol, metoprolol, or nebuvolol. There are minor things, minor specific things like if you come across ectopics kind of things, we tend to use bisoprolol. If you worry about your heart rate, you are using metoprolol. If you are worried about your blood pressure, then you use carvedilol. And the nebuvolol is another novel, very good beta blocker, which can be used even in any condition.
I don't think we have any more questions now. Thank you so much, Dr. Jamaldeen, for your valuable contribution. Thank you.
Thank you very much.
So with this lecture, we are ending up the morning part of this our session, and now we are ready to go for the lunch. Before that, I am going to announce the winners of the competition one. Actually, these winners, they have won 5,000 rupees worth vouchers, and the first name is Mr. Anuruddha Rajapaksha, and the next one is Mr. Ashika Pushpakumar. So congratulations to both of you, and you can collect your vouchers at the SLCC office. Right now we are going for the lunch, and we will be back here in 1 p.m. and please stay with us.